I put the poly in parentheses for a reason, namely there will be some multicystic kidney disease and some cystic renal dysplasia. And in fact, especially because you know this slide by now, the objective of the first part of the talk is to review the nomenclature of and individual characteristics of cystic kidney diseases in children. And then for the second part of the talk, we'll focus on the autosomal polycystic kidney diseases, AD, autosomal dominant, and AR, autosomal recessive polycystic kidney disease, because they have some special relevance to us, both in pediatrics and later on in adulthood as well. And we have an opportunity to base that second part, that review in the second part of the talk, on some recently published guidelines that I'll mention. Now, cystic kidney disease in children is quite a mixture of different conditions, and there's a lot of confusion. For example, when we get calls from pediatricians who are taking care of a newborn baby whose mother had a prenatal ultrasound and some cystic changes were noted, and then a follow-up ultrasound was considered or even performed after delivery, and then a radiologist reads it and puts something in the diagnosis, and then depending on what the nomenclature is, that can cause all kinds of confusion. And so it's important to be aware that cysts in kidneys in children can mean a lot of different things. Obviously, there are the hereditary cystic kidney diseases, and those are predominantly the autosomal dominant and recessive polycystic kidney diseases. There are a few others as well. Again, those are hereditary, meaning typically, not always, because they can be due to new mutations, but oftentimes familial. But then there are a whole number of systemic diseases that can also be inherited, that as part of their overall spectrum of findings include cystic changes in the kidneys. So one of the questions is always, thanks for sharing what the kidneys look like on ultrasound, what does the rest of the baby look like? Are there any systemic findings that would require pursuing one of these diseases more seriously? And then there are non-hereditary kidney diseases that here in this recently published review are listed quite generously, and because of that, and because again they can be cystic changes associated with a whole bunch of other things, but when they're sporadic, I want to especially point to two diagnoses or two conditions, which is cystic dysplasia and multicystic dysplastic kidney, because their nomenclature becomes very important in terms of what that means, both diagnostically and prognostically. And what I mean by that is, I just made my arrows go away, there you go. What I mean by that is shown in this slide. Cystic dysplasia is a congenital, developmental, typically condition. As you know, and as I mentioned in one of my talks earlier, the kidneys and the urinary tract develop fairly early during pregnancy, and they start out with a chunk of cells that start out where in the bladder would develop in the future, and then urinary tract and kidney development essentially progresses upwards like a branching tree. And there are many opportunities for that to not go quite right. And one of the end results can be these types of conditions, both cystic dysplasia and a medullary, a multicystic dysplastic kidney. So congenital, developmental, they're not hereditary, and therefore there's also a very low recurrence risk in future siblings. And cystic dysplasia can occur unilateral, bilateral, or in a solitary kidney. So just something didn't quite go right during kidney and urinary tract development. The same is true for a multicystic dysplastic kidney. The only difference is that, by definition, multicystic dysplastic kidneys have absolutely no function. So if you have either a solitary multicystic dysplastic kidney or two bilateral multicystic dysplastic kidneys, then unless you go to, as a mother, unless you go to a fetal care center and get amnio infusions, which is still highly experimental, as mentioned, that baby is not going to survive because that baby will have no kidney function, therefore no urine prenatally, therefore no amniotic fluid, therefore no adequate lung development. Cystic dysplasia, on the other hand, has some cysts in the kidneys, but clearly some working parenchyma that may not look normal on ultrasound and may look echogenic, but you can see the parenchyma. There is urine production. Kidney function can be a whole spectrum of close to normal to impaired, but still present and enough to make urine. And those are the kids. And you can have dysplasia without cysts. Usually those kidneys just look echogenic, oftentimes small, in which case we would call it hypodysplasia. And these kids with cystic dysplasia, bilateral, or in a solitary kidney, or hypodysplasia, these are the kids that sometimes will live into teenage until they, with chronic kidney disease that progresses subclinically, and until they either stop growing or until they develop severe anemia as a complication of their slowly and subtly progressing chronic kidney disease due to these dysplasias. It may go completely undetected if there is no routine ultrasound that might have pointed people in that direction. And every year we admit 1 or 2 children who, as they have grown older, have developed end-stage renal disease, finally fell off the cliff, get admitted with a BUN of 250 and a creatinine of 10, and you get an ultrasound and they have small echogenic kidneys, which they've probably had all their life. It just never caused enough symptoms or concerns until things had gone really bad. So that's always quite the blow to these kids and their families. MCDK, on the other hand, morphologically, those kidneys are basically just cysts. That's why the ultrasound appearance of an MCDK has been deemed a cluster of grapes. And you don't see any parenchyma between those cysts. They're just a cluster of grapes, which makes sense because these kidneys have no function. And in fact, if there's question postnatally, if a kidney on one side is just a cystic dysplastic kidney or a multicystic dysplastic kidney, then one way to determine that would be to do a nuclear study to see if there's any blood flow to that cystic kidney. And by definition, multicystic dysplastic kidneys have no blood supply, have no blood flow. You don't see them on a nuclear scan. There's just the other kidney, hopefully, that has good uptake and nothing on the side where that cystic thing is, and then you know it's a multicystic dysplastic kidney. There are some contralateral abnormalities possible. There's an increased incidence, for example, of vesicoureteral reflux on the contralateral side in MCDKs. But that's something that we have different styles and different philosophies as far as pursuing that. The good news is especially if you're sure you're looking at an MCDK, those MCDKs almost always don't cause any trouble, and eventually they can get bigger after birth, but after a year or two, they should start to involute and shrink, and 10 or 15 years later, these may be people who are in a car accident and get an abdominal CT to look for a liver laceration, and the radiologist says, oh, your liver looks fine, but by the way, you only have 1 kidney. It's possible that that's a former MCDK that has completely gone away. And then I put this back up just to remind you of all the whole spectrum of cystic kidney diseases. As far as the autosomal polycystic kidney diseases are concerned, again, there's a DPKD. There's a reason why it's named that, because it's usually autosomal dominant in inheritance, although a certain number of cases are new mutations. The affected genes and proteins are listed here. We usually in pediatric nephrology don't see a lot of patients with ADPKD because it doesn't become manifest until adolescence or adulthood usually. However, we get a lot of questions and may see some patients whose family history is positive for ADPKD, and then there are different practices and different styles. Do you get an ultrasound on a child to see if he or she already has cysts and is affected, or if they're doing fine otherwise? Do you not worry for a while? So those are some cases we see in our clinics. And on ultrasound, ADPKD does create visible cysts at some point in a patient over time. It can take up to 30, 35 years of age to see the first cysts develop, but eventually you see cysts on ultrasound in affected individuals. And the renal involvement, again, is cystic kidney disease. There can also be cysts in other organs. And in certain families with ADPKD, there's also a pretty high incidence of intracranial aneurysms, and there are recommendations who to screen for that, depending on their family history. Over the time of these patients' life, there's a 50% chance of developing end-stage renal disease. Now, ARPKD is also due to a mutation and an abnormal protein product, but it's inherited in an autosomal recessive fashion. And many patients manifest pretty early in life, and we'll see in here details in just a little bit. The interesting thing about autosomal recessive polycystic kidney disease is that on ultrasound you don't see cysts, because these patients have microcysts, and their ultrasonographic hallmark are very large and quite echogenic kidneys instead. You don't see cysts on ultrasound in these patients. As we know, there's renal involvement that can be pretty severe, but ARPKD also almost always comes with a degree of congenital hepatic fibrosis, and in fact, in some patients, the liver disease is worse than the kidney disease and drives care. We currently have one teenage boy on dialysis who's waiting for a combined liver-kidney transplant because he has both end-stage renal disease and severe liver failure. So hopefully he'll get transplanted pretty soon. If the ARPKD occurs early enough, even prenatally, then there are also problems with amniotic fluid that can be decreased to the point where there's some component of pulmonary hypoplasia as well. And the end-stage renal disease risk is higher and occurs earlier in life in ARPKD compared to ADPKD. I added a few more things to that table. ADPKD is the most common hereditary kidney disease with an incidence that I've noted here. It can overlap because the mutation can be so large that it involves not just the polycystin gene, but also the neighboring gene that's mutated in tuberous sclerosis. So there are patients who have both, who have a hybrid form of TS and ADPKD. The usual clinical manifestations, again, don't happen until later in adolescence or adulthood, but there are patients who are born into a family with ADPKD, and it is decided by somebody to get a screening ultrasound or to even do genetic testing, and then we're asked what that means and what to tell the family. The goal in ADPKD, where these cysts can be large and continue to grow both in size and in numbers, is to minimize that growth and to minimize how the remaining working parenchyma of these kidneys gets damaged by those increasing numbers and sizes of cysts. ARPKD, like I said, is rare, but there can be early clinical issues, both on the kidney and on the liver side. We talked about the ultrasonographic appearance of these kidneys, and there is a version of severe pre- or neonatal ARPKD that can be potentially lethal, and I told you about our fetal care center in a previous talk. This one is, this next picture is from our fetal care center in Colorado. This is a patient who is currently in our hospital and about 4.5 or 5 months old, and she came to us while mom was pregnant with her because mom was noted to have several things. One, here's the baby, the brain, the liver, and you see these large echogenic kidneys, The other thing you also see is there's neither urine in the baby's bladder, nor is there amniotic fluid, hardly any around the baby. The only urine or fluid you see is, again, urine in mom's bladder as a reference. And so this, the other interesting thing about this patient is they didn't come to our attention until much later, namely in the early 30 weeks of gestation, and we knew from outside evaluations that there actually had been amniotic fluid into the critical time for lung development, into the 20-25 week gestational age. And our fetal MRI radiologists actually told us that the lungs looked promising in terms of survivability because there had been some fluid until this late point in time during pregnancy, and then those kidneys completely shut down. And so eventually this baby, without any prenatal interventions, was born, had quite survivable lungs, has never made a drop of urine in her life, however. So we had our hands full, which we'll mention later, trying to take care of her, because this baby with absolutely no urine output is obviously an order of magnitude more challenging than this boy with obstructive uropathy who still had urine output to help us with his management and delayed dialysis initiation for at least a month or two. Anyway, a DPKD looks like this on imaging and can have additional complications involving the kidneys that can be seen on ultrasound. It needs to be differentiated from nephronophthisis. I don't like this ultrasound very much at all. From renal tumor syndromes, like they can be cystic Wilms tumors, as you know. And then it's always a little bit challenging, especially in very young patients who get imaging, to differentiate cysts from hydronephrosis. This is a good example because you can see how these fluid-filled spaces communicate with each other. So they're not isolated cysts, but they're communicating entities. And so this must be some sort of hydronephrotic condition and not polycystic kidney disease. Extrarenal manifestations, we talked about cysts being possible in other abdominal organs as well. There are other complications. I mentioned intracranial aneurysms, and there are some other imaging examples for the extrarenal manifestations of a DPKD shown here as well. If you look at the organ and the tissue itself, again, here's a DPKD. Here's a kidney. The kidney is full of cysts that you can see with your naked eye, that you can see on ultrasound. And these cysts histologically are dilated tubules, actually. Whereas in ARPKD, there is loss of corticomedullary differentiation macroscopically and on ultrasound because of this diffusely increased echogenicity. But you don't see a cyst with your naked eye, just like you don't see it on ultrasound, but histologically, under the microscope, you can see the cysts, and they're actually dilated collecting ducts in ARPKD. So we have management guidelines for both conditions in 2016. These are mostly pediatric nephrologists got together and came up with some guidelines for ARPKD. Obviously, those guidelines have to be very broad because, as I said, the onset and the severity of manifestations of ARPKD can be very, very variable, and obviously you need to tailor your management based on that severity. So I won't talk about these guidelines anymore. Our adult colleagues have a good time coming up with all kinds of guidelines and expert statements and consensus statements for a DPKD. Here's one from a fairly recent publication that I'll go into a little more detail about. Now, for a DPKD in the adult world, there are a variety of criteria that have been validated to predict progression risk to end-stage renal disease, and some of the algorithms for that prediction are listed here. How quickly do you lose kidney function? And then TKV stands for total kidney volume, which is obviously a measure of how many additional cysts pop up over time and how much do those cysts grow, because if either is the case, the kidneys just get bigger and bigger and bigger and cause more trouble within the kidneys to the working tissue and around the kidneys. And so total kidney volume is a big deal in ADPKD. And then there are some genetic factors that can be incorporated as well. So there are some tools to predict for individual patients with a DPKD how likely is that person to reach end-stage renal disease and potentially how quickly. There are also, just like in lupus, which I mentioned earlier, there are these supportive measures in ADPKD for which there are recommendations. Blood pressure control, we'll talk about that some more. Fluid and salt intake control, and generally a healthy lifestyle because of the increased cardiovascular risk related to the kidney disease. Quit smoking, increased physical activity, normal body weight. Not much of that sounds like rocket science. This is a fancy algorithm that shows how a DPKD progression is in large part driven by upregulation of the renin-angiotensin-aldosterone system. Without going into too much detail, if somebody with a DPKD hasn't very progressed chronic kidney disease, close to end-stage kidney disease, in which case it wouldn't be a good idea to target their renin-angiotensin system because it could make potassium and kidney function even worse. But in patients earlier on during the course of ADPKD, using an ACE inhibitor or an angiotensin receptor blocker, meaning drugs that target specifically the renin-angiotensin system to control blood pressure and minimize proteinuria, is actually a good idea, and that's what many of the studies have done. And then our adult colleagues who wrote this review came up with this table, which of course you can't read, and that's intentional, because they said, oh, now we're on the cusp of having many choices for drugs to limit the progression of ADPKD. mTOR inhibitors have been tested, tolvaptan, and they just list a whole class of statins, a whole class of interventions that, as they say in their conclusions, have been a breakthrough in our understanding and in having development of entirely novel agents, repurposing also drugs as described above. So the future is looking promising for ADPKD. Well, that's a nice and optimistic way of looking at things, but it's not the entire truth, because many of these drugs that are in that complicated table that I showed you, for example, are not available in the United States. They're only FDA approved for people over 18. So many adults with ADPKD, tolvaptan just got FDA approved for use in adults, but many adult patients in the US who read these review articles and want to maximize their access to all these agents drive across the border to Canada to get these medicines, because the FDA is very restrictive and slow in what they approve and what they need for that approval. Pediatric approval is an even bigger problem. We're prescribing a lot of things off-label. We're not supposed to use tolvaptan in children. And again, when you have to cross borders and stuff, it becomes especially a cost issue as well. So it's one thing to be optimistic in writing a review, but in real life, we still have ways to go to maximize and optimize our opportunities to restrict the progression of this autosomal dominant polycystic kidney disease. So it remains work in progress. Thank you very much.